Welcome to another episode of our month-long e-conclave on breast cancer, brought to you by the IHW Council and Novartis India. I'm Anisha Nair, your host for the show. All this month, we have discussed various aspects of breast cancer detection and treatment. One thing which all our experts have underscored is that awareness is a very important piece of the puzzle to solve and thwart the impending breast cancer epidemic in our country. Today, we will discuss threadbare how mobilizing community through communication can help save thousands of lives in India. But before we start the discussion and welcome our esteemed panelists, here's a snapshot of the ground that we've covered in the Breast Cancer Action Month from awareness to action. We kick-started this month-long campaign from the 1st of October. Here's what the experts who joined us so far had to say.
Breast cancer is the number one type of cancer in women today. To exhort and encourage all of us to move from awareness to action, ISW Council, in partnership with Novartis India, embark on month-long mega virtual conclave, Breast Cancer Action Month.
मुझे आज ब्रेस्ट कैंसर एक्शन डे से उम्मीद है कि जागरूकता और उपायों के बारे में लोगों को बताकर हम देश में ज्यादा लोगों के बीच कैंसर होने से रोक सकते हैं।
I'm confident that the contribution of the Integrated Health and Wellbeing Council will certainly help in checking and treating cancer.
Awareness around cancer, awareness around women health, awareness about around all the artificial things that we engage in, and vanity has its own impact on our health. And I think it's time to turn the tables on the other side.
The problem is really at two levels. One is, like I said, with the media centering a lot of communication around what is significant in that month. And the second is, as a society itself, we just don't want to mention the word breast.
We have to create a complete ecosystem which can really help early detection, early treatment, and help patients live a longer and healthier life.
Every morning you get up, you brush your teeth. Similarly, once in a year, for example, it is your birthday, it is your wedding anniversary, or any specific day, you have to go and see a doctor whether there is a complaint or no complaint.
More and more ideas are emerging towards action. And I really appreciate that from awareness to action to make an impact is where we are moving.
I think from the relative's point of view, we need to just give time to the patient, listen to the patient. Do not force your views.
The first treatment of choice for most malignancies in the West is participation in clinical trials. So there has to be a change in the attitude of people towards clinical trials as well.
A holistic approach like awareness and take care of your health, lead a stress-free life and take insurance. So we should provide more budget for the healthcare and more affordable hospitals, research and advocacy groups for cancer patients.
If we do a better job at prevention and at early diagnosis, there are less patients that would need this type of innovative healthcare, expensive care for breast cancer. So I think that's the first thing we should do. We should educate people better through those health and wellness centers, educate them not only on prevention and early diagnosis, but maybe also educate them on the available sources of funding for the disease once they have it.
Preventing risk factors, making sure that all the incentives are aligned together. Everybody is working towards keeping the patient healthy rather than treating sicknesses. So that is, I think, maybe a utopian model right now, but I feel that is the only way out if India as a country needs to put its healthcare system together.
For the middle class people who are not affordable, there's something called as third-party organizations like.
You can also sign the pledge by going to the IHW Council webpage, that is www.ihwcouncil.org. After you sign the pledge, you will receive a certificate with your name on it. Do share the same on your social media pages by tagging 5 people to take this pledge and promote breast health amongst women in our country and to prevent breast cancer as much as possible. Now, as the incidence and mortality rates of breast cancer in India continue to rise, we need to understand what are the drivers of awareness deficit and stigma surrounding breast cancer. Women more commonly believe that unhealthy habits related to alcohol and tobacco are the risk factors for getting breast cancer. Most of them think that if I refrain from this behavior, there is very little risk of getting the disease. Other important risk factors such as family history, reproductive health, and breastfeeding, and being overweight may not have been widely publicized in campaigns so far. So even if there is higher awareness amongst urban women, it may not necessarily always translate to better outcomes. Some evidence suggests a non-compliant attitude of women after getting breast cancer screenings in terms of diagnostic follow-ups for abnormal findings, irrespective of the social economic strata. This is perhaps suggesting there are other factors related to fear, stigma, discrimination, denial, and distrust perhaps in the health system, which may also, impede early detection. So, do awareness campaigns that are run on community level work better to reach out to women and mobilize them into action? These are some of the issues that we will discuss with our esteemed panelists today. So, please welcome our esteemed panelists who are joining us today. We have Dr. Vineet Talwar, Director, Department of Medical Oncology, Rajiv Gandhi Cancer Institute and Research Center, New Delhi. We also have with us Dr. C. Sairam, Director and Senior Consultant Oncologist, Swarna Sai Hospital, Hyderabad. We have with us Dr. Christoph Siffern, Regional Disease Director, Breast Cancer, Novartis Oncology. We have Dr. Priyanjali Datta, CEO, Arogya Carnage Breast Cancer Foundation, and E. Kumar Sharma, Senior Business Journalist, who is joining us on this discussion as well. A warm welcome to all of you, and thank you so much for taking the time to come out for the show. Right, so let me begin with you, Dr. Talwar. In your assessment, what is the level of community level awareness of breast cancer among women in our country?
Well, India, has a universal healthcare model, which means that you have free access to healthcare for all these citizens. And it is not centrally administered, it is administered at the health level, at the state level.
State level.
So state is the one which decides, how the health model goes on. And about, you can say, $35 billion have been spent in 2019 for the healthcare delivery and the systems which are associated. But the problem in India is that unlike other systems, health systems in India are very complex adaptive systems where a change may not follow, the required outcome. And the performance indicators which are there, which you are trying to ask me, they may be dependent upon the conceptual framework on which you make the certain judgments or certain parameters. But still, there is a lot of difference between what you plan and what you achieve, meaning thereby there might be an implemental access in between. And if you see the model in the Indian setup at the community level, in community level, you have predominantly the ANMs, that is the auxiliary nurse midwives. And they are the first contact person between the community and the health services. They form a bridge, so as to say. And one primary health center may have certain sub-centers which have these ANMs, and under them are the Anganwadi workers. So one ANM has about 5 Anganwadi workers under them, and they have again, another battery of workers, which is the ASHA workers, which are the aggregated social health activist workers. Now, this whole program is going on, at the community level and at the primary healthcare level. Along with that, you have certain other agencies, that is the NRHM, that is the National Rural Health Mission, which has the outreach strategies for the underprivileged. You have the DHKC, that is the District Hospital and Knowledge Centers. These are for, a link for training the paramedics and the nurses. And of course, the idea of PPP has been mooted, that is the public-private partnership.
No,
So
thank you, Dr. Talwar, for
yeah.
explaining the entire structure to us, how healthcare is largely decided by each state government and how it is in a decentralized model. ANMs, ASHA workers, everybody, they outreach at a local level. But as much as I understand, most of the healthcare efforts through ANMs and the ASHA workers is targeted towards maternal and infant health. Most of the effort goes there. The awareness, the follow-ups are all here. So I'm talking about breast cancer awareness. To your mind, in your assessment, what is the level of awareness, even if this structure exists?
So, that's what I was trying to build up. When you go to the rural areas, there you don't have any specific people for breast cancer awareness. So these people are the ones which have a holistic outlook, and they, impart all the necessary knowledge or whatever, they can, whatever they imbibe, they pass it on to the people who are there, whether it is the scheduled castes or scheduled tribes. Now, when you come to the urban setup, there, of course, you have all the via medias, you have the health education, you have the health advocacy, you have breast cancer programs, you have the sponsorships, you have screening programs, and of course, you have a lot of telecommunication systems, telemedicines, which come into that. So there is a lot of dichotomy when you see the urban setup and when you see the rural setup.
Yes, you spoke about the dichotomy, and I want to come to Dr. Priyanjali, since she has done a lot of community work. Now, Dr. Priyanjali, Dr. Talwar has explained how the healthcare system in our country works. It's a state, then you have, it decentralized with ANMs and ASHA workers, etc. Yet, if this was an effective model of awareness and creating cancer care literacy, is it really working? Because in rural India, while the incidence of cancer is low, the mortality rate is disproportionately high. Those who will present themselves with cancer in rural areas are generally stage 3 or 4 with very poor prognosis and outcome. What is not working here? Where is the miscommunication? You have a system, but it's not creating the awareness.
There's a gap. I would start with, there's definitely the bridge, but the gap lies in skill set, and the numbers. India is decentralized in structure. It has one of the most beautiful and universal healthcare structure. But at the same time, to increase the efficiency and effectivity, we need to use technology where we can help the semi-skilled wiring, the existing wiring, to impart some skilled knowledge about breast cancer and such topics. Because as you rightly pointed out, ASHAs who are taking care of 1,000 population as a unit, and ANMs who may be handling 10 to 12 villages. And nowadays we also have an additional ASHA facilitator wiring in between the two. There's a layer. We need to impart, with the help of technology, we need to impart them tools so that they can fill in the gap of the skill, because they themselves are not aware completely about the symptoms of breast cancer, if I particularly talk about breast cancer. And to do so, technology is really helpful, because if you go physically to in a country like India, which is like a continent in itself, it's really difficult to do the skill building at such a large scale. The exponential problem, where WHO has already said that 130 million Indians might have cancer by 2030, and we only have 16 to 22 healthcare workers, nurses, ANMs, and doctors for 10,000 people. I don't think physically, this problem this challenge can be addressed. So yeah,
Right. Dr. Sairam, I want your response to this. Dr. Priyanjali has explained to us that a system exists, but given the size of our population, it may not work the best with the skills and the knowledge set they have now. We've had a previous a speaker join us on our show and says, if you're going to leave it to the ASHA workers and the ANMs, you're not going to solve this problem. We believe that they can create a lot of awareness, but ultimately you have to go to a doctor who will be able to tell, okay, is something wrong? If he feels something is wrong, he will refer you to a cancer center. And we have tertiary cancer care centers. What do you think is going to work? Do we need more enhancement of the skill sets of the ANMs? Do we need more doctors at tertiary care centers? How will this work efficiently?
From cancer point of view, hardly we have any system existing, because the system is mainly for tropical diseases, for population control, vaccination, and things like that. Hardly ANM targets, if you see, there's any target of how many patients you could make breast cancer awareness, or how many breast women you could get them screened, how many people you could get them diagnosed at an early age, how many breast cancer preventions you could make, or how many breast cancer patients you are getting them trained. Trained is not the target at all. Our bureaucracy is still thinks that we have tropical diseases, and tropical diseases have to be controlled, population has to be controlled. Our bureaucracy is not geared up for breast cancer or any cancer to be aware that they don't keep that as a part of the ANM's job. Then you don't assign any job regarding cancer. How can you expect them to do something for cancer awareness? Because they, in their job or training program, you have never told them how to do breast cancer awareness, breast cancer screening, or you have not. You have not trained them adequately. We still talk. Then when we are not trained, or when we don't keep the goals, we cannot expect breast cancer to be controlled by ANMs as on now. Unless until you train them properly, keep the targets. This training has to come from straight from ministerial level. When there is a political will, the political will percolate to the ANMs. When there is no political will, you think that this is a far-fetched expectations from ANMs or our system. We don't have any national cancer control program implemented at any level. So how can you expect ANMs or anybody to be responsible for those things?
Right, but Dr. Sairam, don't we have the National Program for Prevention and Control of Cancer, Diabetes?
That's only on paper. That's only on papers. I'm in a regional cancer center. I'm the senior faculty there. The director of the cancer hospital itself is a non-oncology radiologist they have kept for so many reasons other than what we can imagine, for which I'm fighting in Honorable High Court. So when the political system is not geared up to tackle the cancer, which is supposed to be the second commonest cause of death, you cannot expect the things to percolate down to the ANM level.
Okay, that's a very important point. It's a very important point. If you want it to trickle down to the last man through a decentralized effort, the will has to start from the top. Dr. Christoph, I want to come to you to try and understand, what works in the West, because you can't replicate the same thing in India. But the truth is, breast cancer is seen more as an urban problem, and the truth is, you will have higher incidence in urban areas. And the only salient point there is that there is early detection. So there has to be some amount of awareness, things, literacy or awareness, and people present this early. So what works in the US or in Europe that can be replicated here in India, perhaps in the urban audience? Would you have anything to add there?
Yes, thank you for this question. Clearly, in the Western world, we have a wide healthcare system, and we don't necessarily need to distinguish between a rural and an urban area because, for example, in Germany, everyone has access to the same level standard of healthcare, approximately. So this is not the question. And your remark that in an urban area there may be higher incidence of breast cancer because of the lifestyle, and in rural area you may see less. From my perspective, at the end, if you are a breast cancer patient, it doesn't matter because you're confronted with this terrible disease, no matter if you live in an urban area or in a rural area. However, we can anticipate that in an urban area, you have a better infrastructure for the healthcare. You have more possibility to be really checked early. But at the end, it comes down to the awareness of every single woman or even men, which is fortunately very rare, to have this first idea that there could be something wrong in your body. So for me, this is the first step to create this awareness. And I think specifically, one should not have the false perception that when you live in a rural area and you have more traditional lifestyle, that this is a guarantee that you won't develop breast cancer. It can happen to you as well. And therefore, this self-awareness, self-checking is really the first step in hearing that. And what we in Novartis, as we do a lot of research in this area as well, found out that unfortunately, compared to the Western world, in Asia in general, we see more incidence of premenopausal patients, meaning early, younger patients who develop much younger breast cancer. And this is as well a false perception which may be there, that breast cancer is something which happens only to
older people.
To elder people. That's not the case. Clearly, you can argue what is the likelihood that you get it. But at the end, when you are a patient and you develop cancer, the likelihood you had doesn't play a role because today you have cancer and it's not 0 or something in between, the low percentage. It's really you have it and you have to deal with it. So therefore, I think creating awareness among all women that even when you are younger or when you are from a rural area and you live a traditional lifestyle, it still can hit you. And the other important thing is we need to repeat and tell patients, if you detect the tumor early, then you have much better chances if it's detected too late. So I think this is really a message we need to spread out. And there is an opportunity as well. I mean, we're all facing worldwide the situation with COVID-19. So this stops interaction, which we usually would have. When a patient today had maybe an idea to see a doctor, today maybe patients say, I not want to go to a hospital because I'm afraid of catching COVID-19. But there's a risk in this behavior as well, because we may miss the chance to detect the tumor early by not going to the hospital. So we need to find the right balance, taking the risk and seeking help. And what can help during the COVID-19 situation, and this is a worldwide trend we see, we go more towards telehealth, we go more to digital interaction instead of face-to-face interaction. However, a diagnosis of breast cancer can unfortunately not be done via the iPhone or any mobile device. So we need to have this interaction. But at least what we can create with the digital technology is spreading the news, spreading the stories, creating more awareness. And I think this is the first and important step to help in this direction.
Mrs. Sharma, where do you think is the gap in communication? I mean, do you think that the government, because, Dr. Sairam said, you have to have political will. And honestly, there are some state governments that are doing very well. Look at Tamil Nadu, look at Kerala. They have a healthcare system that works pretty well. We've seen it in COVID also. Contact tracing, follow-ups are very active. Now, where is the gap? Is the political leadership not focused on it? Why is it not focused on this? Because the cost of an epidemic will be huge. You will have productivity loss, you'll have healthcare costs. Why is this not there on the map of the political bosses? And can we wait for them to realize the impending crisis?
Yeah, very important actually, and you've raised some very important points as the other panelists have also raised. I think I can give you only a writer's perspective because from what I gather from the ground when I talk to people, uh, essentially, it's good that actually you are. Of course, this is the awareness month, but this is the more worrying time really because in COVID situation, I've interacted with doctors and they say actually we are seeing more patients, percentage of more patients, some as much as 25%. Turning up with advanced case because actually they have neglected some of the treatment. And to the larger question in terms of what is it, where do we see the gaps? See, in the Indian context, we have the ASHA workers, the A&M workers, but the problem is that in the COVID situation, all the resources have got diverted towards COVID, handling of COVID. And we have over the years actually kind of dismantled the healthcare cadre that we had. And there used to be health inspectors and different states. So I think focusing more on building a healthcare cadre will play an important role. Second important point where I see gaps is when I interact with microfinance institutions, when I talk to those who have self-help groups, these are essentially women groups. When you talk to them, when you interact with them, there is not so much of an awareness in terms of what needs to be done. Perhaps because of the inhibitions of this stigma attached and the interaction with the doctors, but I think some awareness in terms of what are some of the self checks that people can do. All those I think need a bit more focus. And the last point which the important point which you also said about highly fragmented situation, like some states in India today have the healthcare spending double that of the national spend on healthcare. They're spending, like, for example, Himachal Pradesh, Maharashtra. There are states, Mizoram, who have actually doubled that of national spending on annual budget on healthcare. Whereas some, like Bihar, for instance, which is in the news these days because of the elections, their spending is 10,000 crores, per year on healthcare. But this vaccination alone will cost them about 5,000, 6,000 crores. So where are the resources now left for other ailments? Non-communicable diseases overall, and in particularly cancer there. So I think these are some elements where we find, worrying aspects which can be looked at.
Right. Dr. Talal, the pandemic is an unprecedented situation. And there are no easy solutions, even for the government. We hope and pray that this is going to be a wake-up call for the government to invest more in healthcare, to make this universal healthcare more accessible to everyone without long waiting lines. But chronic patients can't wait for this pandemic. Nobody knows when this pandemic is going. So how can you just sit back and say, oh, when the pandemic is over, we'll plan a campaign, we start talking about it? How is it hard to talk about this now? If you have started training your ANMs and your ASHA workers on how COVID is to be managed, contact tracing is to be done, information has to be given about, hand washing, etc. Why can't you put in a message about chronic healthcare issues like breast cancer? Why do we need a special campaign and the political bosses to decide that now we're going to talk about this, to start talking about it?
No, Nisha, you are very right in the sense that everything has to go side by side. You can't have isolated silos for each and every specific problem, because the problem at large. See, WHO said that 2020 is going to be the watershed area for cancer, meaning thereby 1 person in each family will have cancer. 10 million people are dying, each year because of cancer. And out of those 10 million people in the world, 70% are in the developing countries. India and China form about half of the world population. Now, if we start talking from the top, that is the political will, I guess it is the other way around. It has to percolate from the bottom upstairs, in the sense that it requires a team effort between the social workers, the healthcare professionals, everybody. It has to be a comprehensive effort, which will bring about dividends. It can't be just isolated. And as far as India is concerned, I personally feel that the way we can bridge the gap is we couple it with our telemedicine, and we can use our telecommunications, because India has the second largest mobile base in the world, and we are not using it to the fullest. If you can reach the people, if you can make them aware, simple things, which people don't know. For example, I'll give you an instance. I went to give a lecture in a place nearby Ranchi, and the tire of the car got burst. And we were waiting for, the driver to change I'm sorry, I'm digressing from the topic. There was a chap there, 14-year-old boy, who was taking care of the sheeps there, the goats, and he was chewing tobacco. So I asked him, why are you chewing tobacco? He says, ye mardandgi ki nishani hai. It's a thing of manlyhood. You chew tobacco, you are identified with the men, and, you gain prominence in the society. Now, if somebody tells that chap that chewing tobacco is very, very bad, and also at this young age, if that kind of awareness is there, our job is done. And if you have this telecommunication base, you can link it up, somehow. I don't know how the logistics will be. Then I think to a great extent, the healthcare burden can be taken care of. These small issues can be taken care of. And if a person, there is a study in 2014 in which 87% of people, they displayed interest in health education and the repercussions, the health advocacy. So it appears to be a very, very tall order, but then if you fragment into small bits, I think it is doable. And the biggest problem is that we try to compare everything with the West. You compare our population of one state to whole of Europe, it is almost the same. So the magnitude of problem is different. And, the cultural, the economical, and the social overtones are totally different from what is there in the West. So many people come to me for treatment in my clinic, and they start talking about the WhatsApp University, they start talking about the Google, and, in India, as they say, muft ki salah, free knowledge is there, which all the attendants of the patients, they tell them, they create fear amongst them. They say, you are just taking allopathic medicine, you should couple with Ayurvedic medicine. You should not do this, you should not do that. So what I'm trying to say is that the situation in India is very, very peculiar. It is not the run of the mill which is there, in any other developed country where you have a basic level of
literacy and understanding.
And education.
Right.
If we fragment it, definitely we can make a foray.
Right. But Dr. Saidam, how do we then get verifiable, trustworthy information? Dr. Talwar is saying use the resource that you have, which is the telecommunication network, to create the awareness about breast cancer and the need to be alert and proactive. At the same time, you have this misinformation going around WhatsApp University, Google, etc. Tambaku mardangi ki nishani hai. Where do you find how do you use your resources to work for you? Dr. Priyanjali said that we need proper training of those people at the community level. That's not going to happen overnight. What can we achieve now with what we have now?
Yeah, at least I think with whatever mechanism we have, we should make cancer as a notifiable disease. Once we see, like why ANMs or why they are not being given target, because that is like that is not the target at all. Once you make it as a notifiable disease, we'll know how many cancer patients we have, what we should do. All those things can come into the charter of the ANMs and all the people. We should request the political parties or public to demand that we don't require 1 rupee rice or fertilization subsidy or small things. That is like if you see average deaths, like in Telangana, we have many farmers committing suicide. I mean, after doing analysis of the suicide patients, suicide people, what was found was that majority of the people who have committed suicide was from cancer and health-related things, apart from whatever the agricultural loss and other things were there. So, if you can provide a system where this particular small benefits government is giving, but more than that, health is a bigger, like unless until you have a health, you cannot expect the family to run. Once like most of the patients, like for cancer or any major disease, they have to spend from their pocket and they get bankrupt. So if you can provide something with which the family will not be depleted of all the resources, like if you see 75% of the patients go to private sector, only 25% go to government sector. Why should this happen? Like I'm in the Institute of Oncology and Regional Cancer Center. That is the commonest. That is the only single regional cancer center for all of Telangana and Andhra Pradesh. Fifth biggest state. If you stay in Hyderabad, I have more than 20 private cancer hospitals. You cannot expect private hospitals to do this preaching of prevention, awareness, all those things. They will not be doing. And you advertise every half an hour about the tobacco, mean like pan parag, all those things. You don't ban those things. And how can you expect the public to know that these are harmful things to them? And see, unless until you make the awareness programs, like fortunately, at least some media are doing the job, but most of the like tobacco lobby, ministers, MLAs, MPs, they demand that tobacco workers are becoming jobless by banning tobacco. What is this? Government is spending 87% from 13% what the
No,
government revenue
Dr. Sairam,
express.
there is no disconnect that tobacco not only causes cancer, it is a problem for many other diseases. But the truth is that that is not the only risk for breast cancer. Are we talking about those risks as well? Dr. Priyanjali, family history, when you had your first child, how much you breastfed, when you got your menses, those are important things to talk about. Is anybody talking about that with women everywhere in our country?
I want to talk about this aspect a little positively because I think we all are talking about the problems. Uh, just to give another flavor, our organization formed a consortium with 23 nonprofit and technology organizations during COVID-19, and we were carrying our work forward. We got grant from UK government, and we could develop AI tools for primary symptom assessment of these questions exactly, uh, which ANM and ASHA at community level can ask. And we triage the patients into high, moderate, and low risk. So that is how we mobilized 200,000 women in 50 plus places in India during COVID-19. And it is also a safer method because it is a simple mobile application. So what I'm trying to say here is that it is not very difficult, and people with collaboration, government machinery, international organizations, hospitals, doctors, and engineers together can really solve bit by bit, as Dr. Talwar very rightly said. Everyone can pick one part of the puzzle, solve it, and create the larger solution. We just need a simple, scalable solution to mobilize them, because awareness won't work. Awareness doesn't work. I come from a state which is a matriarchal society, Meghalaya, and women are the bread earners, and it is a tobacco growing economy. They are chewing tobacco all the time, and it is also a very forward progressive community. So they have multiple partners, and unsafe urinary practices, a lot of factors that play a role. Late marriages, late breastfeeding, alcohol. So communities have different set of problems. I'll talk about another place in UP, Uttar Pradesh, where we have worked, a tributary of Yamuna called Hindon. There are 800 plus villages which is affected by the toxic water of that place, because sugarcane and paper mill industries are causing so high effluent release in the water that according to WHO standard, the drinking and bathing poisonous capacity of that river has crossed Red River. So we cannot call out one solution, one problem agenda. We all have to pick up puzzles pieces and solve one by one, bit by bit, and create a net. So that's how I think it works.
Dr. Christoph, would you have any ideas on what could work in India, taking off from where Dr. Priyanjali left off? She said there can't be a one size fits all. India is too different in different regions, different cultures, in different states. Even in a matriarchal society, women are chewing tobacco. How to create an awareness about good health, where women are not being oppressed. But come to Uttar Pradesh and women don't even want to talk about it because they think, who will pay for my treatment? I'm the last person anybody talks about, cares about in my family. Anything you think that can work? Plus, what most of the speakers are saying, for the government to be seized of this during a healthcare crisis, what part of the puzzle can be worked on from the government side, from other parties that can use technology to increase the awareness?
Yeah, no, thanks for the question. To the first part, and thanks, Dr. Priyanjali, about these factors, which are risk factors to develop breast cancer. I think we can separate them in two big buckets. One is, I would say, external factors like poisonous substances in the environment, or substances you expose yourself, like tobacco and alcohol, which from my perspective doesn't belong to a natural way we treat our body. So these are clearly things where we need to create awareness, and this is specific then to some region or to some behaviors, where we need to make clear, if you decide to consume those substances like tobacco or alcohol, this increases the risk not only for breast cancer but other diseases or other forms of cancer. I think this is clearly important to have the awareness on this. But the second factor, which specifically for breast cancer, is an early menopause, then as well breastfeeding. These are things which happen in your life. I mean, we cannot force women to get many children and do breastfeeding just to avoid the risk of developing breast cancer. I mean, it's their decision, it's their life, their faith, which happens to them if they have an early partner or a later partner. This is their life. And we should not try to influence their life and say, you have to behave like this to avoid breast cancer. I mean, I think that would give the wrong signal. It should be the freedom of the women to have their life planned like this. But what we need to do is give them the chance to be aware that breast cancer can develop in their body early or later, and be aware of it, and give them the chance to identify it as early as possible. So I think here we can use all channels of communication, including digital communication, to make a sound platform of education. I think education is the first step to then think about your body yourself and remove the stigma. It is not something you have done wrong because and
you've been punished for it.
Yeah, I mean, whole life is a gamble. You have chance of developing something, of you having an accident or anything else. It's a gamble, and you have higher chances for some things and lower chances for something. But again, if it hits you, it doesn't matter how big or small the chance was. It is now there, and one needs to identify it and act it. That's for me the secret of trying to capture cancer early and increase dramatically the rate of cure. So I think this is really the first step. So digital media can help in the education, and we need to really build a strong foundation of education to stand out of all the myths on wrong educations, which you may find in Google or so. We face currently a big debate in Europe about vaccination. I mean, if you ask me if there's a solid, proven, evidence-based vaccination for COVID-19, I will get myself vaccinated. But there are many people, and in the internet, there are things going around, crazy things, which are not scientifically based, who tell you, oh, if you get vaccinated, Bill Gates infuses a microchip in you to control
into your DNA. Yes.
This is such a nonsense. So we really need to have the right share of voice and put education first, and scientific-based education. And here we need to work together with the scientific community, with the help of pharmaceutical companies, but as well with the government. Because if there's wrong information there, a patient isn't detected early with breast cancer or takes the wrong steps, this will cause damage to the healthcare system and to the whole society. And that we have a common interest to avoid this by really using all channels and build a solid foundation of communication and education.
Right, Mr. Sharma, there is no doubt that we need credible education and awareness program where we can use technology to reach out to everyone and make them aware that this could happen. Okay, if they are not sure how they check themselves, or if they suspect something, they should go to a medical professional who will help them. This is something we need to educate everybody about. But is education going to be enough? A woman in a village thinks, okay, I know, I think there's something wrong, but who's going to pay for the medicines? Where do I go? What kind of care will I get? Can I do, months of treatment away from home? All these things are like, oh, I think let it be. Why go and get a headache on? Awareness and knowledge is good, but if you don't give them a solution which they can trust, why would they come forward?
Yeah, I think it's very important. I think what you say is very important, and I think it has to be a family's responsibility. When we say, in education, you say teacher, woman, and the family benefits and all of that. I think the whole family has to understand in this, and I think given that if early detection is so critical in this, because many people actually total remission and clear advantages have been shown in breast cancer. So clear awareness, I think the whole family understand that, particularly who are the male members in that, is very important. And second, I think what also needs to be communicated is the reduction in costs which are there. Cancer care, breast cancer in particular, in India, at least for every particular medicine which is there for breast cancer today, there are at least 10 different biosimilars available. There are alternate cheaper medicines available today. So the cost of treatment has tremendously come down. I mean, I remember a time few years ago, Herceptin, I think the whole treatment used to cost something like 17 to 20 lakhs. Now it's got about 3-4 lakhs. I think there's price control, and so I think that also needs to be understood, that there is a reduction in that. That it's not early detection is very important. Second, that the cost has come down. Third, I think the adverse, if it is not taken care of, how detrimental it can be, as they describe is the years of life lost. When a person dies compared to when the expected age of death when is there in each country, it varies. So the years of life lost, I think this if this message is conveyed, I think it's very important, and I think the family involvement is more critical here.
Right. So, Dr. Talwar, community mobilization is important. Mr. Sharma is saying family needs to be sensitized as well. Now, there was a study where the Kerala government involved ANMs. They trained them and they involved ASHA workers. They did a survey where these ladies went to each household and they orally checked for a few risk factors. After that, those who were high risk were taken on for mammograms, etc. And those who were found with breast cancer were treated. So this way, this was a successful model which worked in a particular district. Now, how can this be replicated on a nationwide basis? How can we increase, the training and skill needs of ANMs? Because once the healthcare staff is also proactive and understands all the risks, then if they have an opportunity to come in touch with women for any other issue, like the maternal health program is a well documented one. So if you're going to tell a new mother, see, this is how you breastfeed, it's best that you breastfeed for exclusively at least for 6 months, and then preferably till a year. You can also add one line saying that if you do this, you will reduce your chance of cancer. And later on, once your kids are grown up, you can start doing self-checks. I'll show you how a self-check is done now. Don't forget about it. If you have any questions, come back. How can we get this training going for ANMs and increase the awareness in ASHA workers also, that once you start talking to women in communities, perhaps they'll be more receptive of from the risks that are and be a little more aware.
Nisha, you are right. See, India, no one size fits all. As Dr. Priyanjali said, that in her state, they marry late. Go to Rajasthan, all of them, they marry early. 12 years, 14 years, it's a norm. So you have one spectrum and you have the extreme side on the other side. So having said that, the health support systems, they have to be geared up according to the
local conditions.
The local conditions.
Okay.
And health education, everybody, all of us agrees it's a must. But then what is the local prevailing environment? You have to go according to that, Suppose you take a state, you'll have a difference of opinion when you go and check a person in an urban area vis-a-vis you go and check a person in the rural area in the same state. You might have a difference in the socioeconomic strata. People who are wealthy, because of their wealth, they can get access. People who are poor, because of their poverty, they cannot get access. Gender is the most important part in India, unfortunately. Even today, if it's a child, if it's a male child, he'll get preference over a female child as far as treatment is concerned. All of us just shy off, but then that's the reality. Same goes for the education. A male child will get more education as compared to a female. And this is the reason why you have more of maternal mortality deaths in India. So having said all that, the thing is that everything has to be united so that you can go forth, but then keeping in view of the local conditions which are prevailing in that part, and what are the facilities which we have from the government, from the private side, how can it be effectively utilized? But I again feel that there is health education is a must. If you can educate the people to a certain basic level, then I think most of our problems can be solved.
Right. Dr. Sairaf, previous speakers have come and said that health education should start in school. Maybe at class 9th, 10th levels, we should start talking about all of this. This is the right age for kids also to realize, what are risk factors, and they would pay attention because at that point in time, they wouldn't have a lot of academic pressure, etc. So we hope that the government takes this seriously. But you mentioned that in your state, there are 20 private hospitals for every one government hospital. There are 20 hospitals because there is a demand. There is a problem of people having cancer. Now, you're saying you can't expect the private hospitals and the private industry to do a lot of awareness and everything. They're doing their bit by treatment. Now, how will we then overcome this hurdle? Into your mind, what is the best way to train the existing network we have of A&M, of ASHA workers, use technology? Because previous speakers from Novartis have shown us how AI is being used, how the algos can help in early detection of a cancer that then does reduce the cost and the time and improves the outcome of treatment. How can we use our current system to increase at least the healthcare workers and the community workers' awareness and proactiveness?
Yeah, I think we should make an Arogyasri scheme. Cancer treatment is covered, but diagnostics are not covered. So unless until we make diagnostics to be covered, and we have at least 50-bedded hospital to be empaneled for Arogyasri. So if we can make it to lesser capacity also, small setups, like say, as per WHO, what the cancer patients incurs maximum expenditure is on travel, because they have to travel all the way from different parts of the country to a regional cancer center or a cancer treatment facility for almost 1 to 2 years. Cancer treatment takes 1 to 2 years, and the burden of travel is more than
treatment cost.
Actual treatment of drugs or surgery or all other things. So that's why government gives a train pass, bus pass in Arogyasri and also this. So at least if they can make investigations covered in the this Aragasri or PM scheme, to that will make the workup done. Let's say, for example, if a woman requires mammosonography and ultrasound guided core needle biopsy, if that can be covered for any of these
But
schemes.
Dr. Sairam, this is being done in Tamil Nadu. In Tamil Nadu, you can get a mammogram done for 200 rupees. And
see, in MNJ, digital consent itself, we are charging mammosonography 500 rupees. So I don't think in Tamil Nadu, 200 rupees, in 200 rupees, you cannot even get ultrasound done.
No, we had a doctor who came and told us that the government is providing this kind of healthcare facilities in government hospitals.
See, that Tamil Nadu is a different issue.
Yeah, that I completely agree with you.
Issue.
In Kerala, in Tamil Nadu, governments are spending more on healthcare and subsidizing many of these costs. I'm saying, how can you increase the awareness amongst health workers so that they start talking about this? Because Dr. Christoph has also said, use the technology that you have. You have algos. Dr. Priyanjali has said they've developed a simple app by which they're doing questionnaires, etc. Any ideas on how technology can be leveraged so that at least amongst the healthcare workers, we can increase the skill level so that then they can also help detect, do proper self-breast clinical breast examination should a woman have a problem, detect a lump early on.
See, like this self-breast examination, WHO has told that they are not supposed to propagate that one because the women who have undergone breast self-examination versus the woman who has not undergone, there was no difference at all. In fact, there was a false confidence in the breast self-examined group, and the WHO recommends that we should no more propagate breast self-examination because it has not served any purpose. All over the world,
studies show that it doesn't work, but I'm saying in our country, we should
in our country
then
or any
move
other
to clinical
country,
breast exam because we can't do mammograms for all women. And I mean, we are having cancers at 40.
That's what if we can include these things in Aragasri schemes, that investigations are also covered. And if we can make at least whatever centers we have, the digital centers, enable to get at least some ultrasound or some X-ray facilities, it will be more economical for the women than government also. It will be more economical than spending huge amounts on treatments, like accepting even in any government schemes, it will cost at least 3 lakhs. All those things can come down if we can make these things available at a government setups,
at a cheaper rate.
Yes, or at least if government cannot make it available right now in the primary health centers, at least they should make it a part of the Aragasri or any other schemes, Prime Minister scheme or any other scheme, that investigations also has to be covered.
Right.
Whether they get, see what happens is only if they're diagnosed and getting treatment, that is covered. But if they don't diagnose it as a cancer, they are not covered. So no hospital will spend from their pocket to diagnose and tell that you're not having breast cancer, you're having only this fibroadenoma. So those expenditure, the people have to bear from their own pocket.
Dr. Priyanjali, what has been your experience since you have done work at a community level, research level with women? Is there any reluctance from their side to seek further treatment or to follow up on a treatment after something is detected because of either cost or stigma, or once they are aware that this could really impact them badly, they are willing to go ahead? What have you seen in your experience?
There have been multiple test and trials over last 4 years, Anisha, and in my previous years of education, coming from a government college. Family takes the ownership, especially the husband takes the ownership. And it's very important to mobilize not only the women, but also to counsel the husband, because in India, mostly the decision maker is either father or husband, and India is seeing a lot of triple negative breast cancer cases, which is happening in younger women. What we have seen is that if you holistically design a program where you do give them a fear factor that yes, you do fall under the high risk category, they do get motivated enough to mobilize and take action. But if you just go and do an awareness camp, in my experience, it hasn't worked. It hasn't worked because if you want to do an awareness camp, you have to do it as a subject, like we teach brush your teeth every day, and it has to be deeply imbibed in the society, which will take years now, and I mean decades. But I think right now what we need is early detection. We need to put up the capability in our country to enhance and enable early detection of cancer. And 10 years is not a long time, given the condition we are having, and with COVID-19 it's all aggravated. So women are not reluctant to take action, but we need to create that ecosystem for them to facilitate the action for them. So that's what my experience has been.
All right. So we need to facilitate a foundation so that women can go ahead and take follow-ups and take the required action. Mr. Sharma, Dr. Priyanjali mentioned about the Hindon River being so polluted. We in Delhi are breathing the toxic air, which will obviously hit us one day, and our kids also, but we can't do anything about it. What do we do? Those who are living next to the Hindon can't get up and go somewhere else and start living a life. What do we do of these risk factors?
You're saying risk factors relating to pollution?
Yes.
In the context of breast cancer?
Yes, pollution, lifestyle. I mean, the thing is that these are not being taken seriously as risk factors by the powers that be.
Yeah,
so, I mean, how we want to create this awareness that, if I have not breastfed any child till 40 years, I could be at high risk. If I have started my menses at 9 years, I could be high risk. You're talking about all of this. How about, toxic air, the toxic water you're drinking? We don't talk about this. And the powers that we don't think it is important. So do we need to communicate about this as well?
This, I think, very important. This, of course, has to be emphasized and re-emphasized and drilled into people. Very important. Along with that, I think since breast cancer is a lifestyle problem, I think this whole focus on diet, obesity, fatty foods, I think till that is also, I think whether it is urban or whether it is rural, the message on diet has to be also grilled along with this. I think people need to be conveyed very seriously on this, and it's high time. And COVID has aggravated the problem, and I think we need to emphasize on that as well. And the other point which I said about, this, when we say about the, communication, reaching out to them, the reason I raised the issue of a healthcare cadre, when we talk of ASHA or A&M workers also, we need to have at least a mechanism to incentivize the person to go and tell. Why should an ASHA worker today in a COVID situation wearing a mask go to somebody's house, get in there and say whether you got a breast cancer or not, let me examine your chest, or this is what you need to do. We have to have an incentivized structure for that. And there are healthcare budgets which I think facilitate that. We used to have structures earlier. All we need to do is just activate that. And final point which I also need to mention is this maybe perhaps I think the expertise from Novartis that we have, perhaps maybe that can help here, is some element in terms of what science can provide us in terms of the way it is monitored and examined. I think also they need to come up with innovative ways in which the probe can be done. In this case, it need not be a physical examination. How it can be, I have read of situations where actually probes are being used, which can, through we can measure the calcium deposit, and it's not necessarily that an injection is injected and then you get a biopsy done and all of that. I think some manner in which this can be made less invasive. I think those elements, if they can, if we can work a bit on the innovation side, it can at least start solving in the urban areas this problem, and we could get to rural as well. And last point, if I may just add, is the point about connecting. I have come across people, many in rural India, where actually they want to connect with the hospitals, major hospitals, for having mobile scanning units. And there are people and there are philanthropists willing to fund that. I think we just need to focus on getting that network in place. We have a rural, panchayat setup. We have a local hospital, maybe a private hospital there, and we need a philanthropist there who are there available today. Just need to build that network there so that mobile scanning was also made possible. So there are models which can be tried.
Right. Dr. Christoph, taking off from what Mr. Sharma said, now I have heard about this thing called the mammo bus, a bus which has, a mammogram, and it goes around a few villages and it scans women. These are typical solutions for conditions in India. Okay. And we have seen Mr. Sharma talk about philanthropists. Even companies are interested to do this as part of the CSR because, their workers live in a village, so they want to ensure their well-being, etc. So, what would be the technological solutions to this? Previously, we've had speakers who have told us that algos are being used for early detection and filtering out high-risk people so that they may be given more attention. What do you think would be the technological solutions that could work in India?
I think there are two important parts. I mean, when it comes to awareness or assessing the risk of a patient, this is a thing which can be done to technical solution, meaning you don't need a face-to-face interaction, which is especially now important during the COVID-19 situation. So one could issue questionnaire and trying to assess the risk of a single patient through that, and by that creating awareness. So I think on the risk assessment and on the awareness and education, clearly digital technologies can help. But when it comes to a physical examination or a mammography, you cannot do this via your smartphone. You need to have this contact. And therefore, I think this mammography bus, this is an excellent thing to do. And I think you can even make it stronger. If you have a bus like this coming to a smaller village, and it's not that the bus is there and one woman goes in and gets a mammography. You need to use this opportunity that the bus is there, and you give education as well to the village and invite patients to go in there and check. So you can serve two parts. You can serve the awareness, the education, and the mammography then. And then help as well, what are the next steps? Because that's often the disconnect. You are aware, you may even find a diagnosis, but then the question is, what are the next steps? Where should I go and get the treatment? So therefore, you cannot just send the bus without a follow-up on that. So it needs to be linked to a nearby center, and the center needs to be ready and prepared if patients coming then from that village and seek help, that this can be provided as well. So I think that is something. Then later on, when a patient has been diagnosed and initially treated, then technology can start as well. I mean, unfortunately, we cannot do a blood test via the mobile phone. So you have to have, again, a physical interaction to draw the blood if you want to measure something from it. However, the digital technology can still help to maintain the awareness that the patient even realized after 3 years, after the breast cancer surgeon, still taking, for example, if it's a hormone-positive breast cancer, still taking the aromatase inhibitors, that it's needed to continue this treatment. So keeping this awareness, the alertness of the patient high to watch out for symptoms. Here, again, education and digital technology can help. And even with the compliance with the treatment, because it doesn't help us as pharmaceutical companies to invent new treatments if they are not taken as they should be by the patient. So here, helping as well with being what we call compliant with the treatment scheme, that is as well a thing where digital technology can help and optimize the outcomes with the treatment. Because if compliance is not there, if the patient decides to take the pill instead of every day, every 2 days only to reduce costs, then we know that the treatment will not work that way. And then it's a waste that the patient spends money or the healthcare system spends money to take the treatment if it's not taken in a compliant way, because otherwise it doesn't work. So these are clearly elements where digital technology can help, but you have to build it around the face-to-face, the physical contacts, which needs to be there to do a mammography. We cannot do it remotely, or if there's a blood test to be done. These interactions need somewhere to be there, but we need to integrate it in a system which supports at least the awareness, the risk assessment, and the education via digital platforms.
Dr. Priyanjali, I want to check from you, since you work on the community level, what role can the industry play in this? Like, in urban settings, companies can perhaps, they give executive checks, allowance to their executives so that they can remain healthy, because the company also pays a premium for their health insurance, etc. It's a wise thing to do. What more can the industry also do in this? Should they involve this in their CSR efforts? Does that work effectively? Should they do this in their offices? Create awareness, offer clinical breast examinations. What can the industry do to increase the awareness?
Industry can play and is playing a very vital role. Arogya has been funded several times by multiple CSRs like Cisco and Schlumberger, and they are doing active work not only in creating the solution for their local community, but Cisco has funded us to create this AI model for the whole of country, and now we have exported to Africa. So this is where the philanthropists, strategic philanthropists, and CSR can play a vital role to create a scalable model and incentivize people to come and get this primary assessment done, so that at least the first level of mobilization can happen. And I want to also highlight that industries with COVID-19 and CSR money will take a bad hit. It will take a bad hit because we are struggling to make profits due to the pandemic. We cannot depend on philanthropy always. We have to create strategic philanthropic way and sustainable ventures to do this effort on ground, because it cannot only run on donations. It's where I'm trying to point at. So yeah, that's my take on
If it can't run on donations, what will it run on? You're not making profits. Many companies are not going to make profits.
Absolutely. I'll give you a small example. Like, from us, a very small NGO in Africa bought this and integrated in their telemedicine platform. It's a small revenue, but it gives us the capacity to keep running. And revenue has to come to social enterprise, and CSR has to invest to make a social enterprise sustainable. Only then efforts like this can stay on ground
And remain sustainable. Right.
Will keep hitting.
Right. Dr. Talwar, in urban settings, what works in abroad, like, the marathons, the breast cancer marathon, or your check with your buddy. Did you do your self-exam every month? Are these campaigns going to work in urban settings? When we see patients, who go to doctors for regular checkups or any small health issues, are doctors counseling them enough about lifestyle as a risk for cancer, any type of cancer? Are we doing that enough?
Well, you ask me frankly, there is, paucity of time when you're seeing the patient in the clinic. To be very frank, if I just say on a, what should I say, on a ideal note, I'll put it that way. Yes, we'll do this, we do that. But if you see a patient in the clinic, to be very frank, there is a paucity of time. But then in that time, we direct our, energies towards the problem at hand. And side by side, if possible, we try to explain them. But then fortunately at our institute, we have layered services. We have the social workers, we have the counselors, we have the molecular counselors who counsel about the family, the cancers which go through the families. So we take help of them. And most important, we take help of the cancer conquerors. We have 2 or 3 support groups. And the best way I feel is that if one of the persons who has conquered, we don't call them cancer survivors, we call them cancer conquerors. If they go and tell the patient that, look, I am a living example in front of you, and I am, doing fine, or I am as bad or as good as any lady outside, you probably would be the one who will be able to do that. Gives them a reassurance. And let me tell you, a positive environment like this works wonders. You have a lady who is not positively charged, you have a lady who is depressed physically, emotionally, financially. Of course, India is a very, very price sensitive market. So if you have all those odds against you, vis-a-vis you are positive, then definitely the drug works better. There are a lot of studies to tabulate that.
Yes, and Dr. Talwar, on our shows, we had nearly on every show a breast cancer survivor or a cancer survivor come and talk to us
I'll
about their
never call them
experiences.
cancer survivors. I'll call them cancer
Conquerors, yes. We've had at least one join us on every show to talk about their experience. But Dr. Saran, what I'm saying is, you're an oncologist. Dr. Talwar is an oncologist. When a patient is presenting to you, it's very late in the game. They already have cancer. But for a regular checkup, I don't go to an oncologist. I go to a regular doctor, a GP, or a specialist. Even they can talk about these things, about risk. Are they doing that enough?
No, there is
sorry to acknowledge that there is hardly any master health checkups done by most of the diagnostic centers or hospitals. They don't include cancer checkup as part of the master health checkup. If you see any like insurance checkups or any other checkups, like I was in armed services, in annual medical examination for armed services or DRDL defense services, so many services, they have checkups, but in that mostly BP, sugar, cholesterol, or I think only those things are mentioned, but never a pap smear or a mammogram or things pertaining to oncology are incorporated into this checkups. Because we probably at that juncture, when it was framed, maybe almost 50, 60 years back, that awareness was not there. But now, at that particular period, there were more TB or infectious diseases. But now is the time when we should incorporate in all these checkups, at least some basic screening investigations as a part of the checkups, because it will help the country and the individual also getting. Because most of the people who come out of these checkups, they land up in a terminal stages, and when we see their reports, they have everything else: BP, sugar, cholesterol, thyroid, everything else, because those checkups have been framed by endocrinologists or cardiologists. In this scenario, oncologists also has to be incorporated in framing these checkups from various sources. I think then only probably we will be able to diagnose them early.
Right. Dr. Talwar, in our country, I don't know if we can have, screenings like a mammogram at a wide level for all women in our country. Plus, from the Western world, where we differ is that since we are getting younger cases of cancer, just given the population of younger people in our country, sometimes, it's not so easy to detect cancer on a mammogram. I mean, like, when do you start, even if you have the resources to do mammograms, for everyone, when do you do it? In developed countries, it generally starts at 50 or 45, that you do an annual mammogram as part of a screening. Now, in India, you're getting so many cases at 40. Perhaps, the breast is so dense, you will not be able to detect it on a mammogram also. Then what is the solution?
Well, to be very frank, as far as our scenario is concerned, we don't have mammography on a routine basis. What we call screening in India, it is elective screening. It is not routine screening what is done abroad. By elective, I mean that the person who feels that there's a problem, she goes to the place and gets herself investigated. We don't go. Of course, there are small pockets where you have the mobile units who go and check. But as a policy, it is elective screening.
No, elective screening is a clinical breast exam. Is that what you're saying?
No, elective screening is if some lady feels that she should get screened, they go to the hospital and get a mammography done.
Okay.
Now, the second part of your question is that if it is a young lady vis-a-vis an elderly lady, the best way to do is a MR mammogram. It should not be a routine mammography, because young ladies, about 35 to 40 years, they have a very, very dense breast. So sometimes a conventional mammography
Mammogram will not detect.
So they are the ones in which we do a MR mammography. Now, coming to the third part, the availability and the resources. I keep on giving examples. They might appear very foolish. I got my medical oncology training in Chennai in Cancer Institute. Is one of the most reputed and the oldest centers. I got a lady there when I was doing my DM from a hinterland. We have a drainage from Kerala, from Andhra Pradesh, and from Tamil Nadu. So this husband and wife couple came from hinterland from Andhra Pradesh. And when he came here, we prognosticated everything, gave him a very rosy picture. We did everything free. And then we said, should I start the treatment? The husband started crying, He was at my feet. Now, on deep questioning, he told me that, sir, I had only enough money to get my wife by the bus. I had the money to pay the tickets only. After this, I don't know how I'll eat, how I'll go back. And you're telling me treatment, I really don't know how it will happen. So we created a mechanism there where the patient will stay, the attendant will stay, the food for the attendant and the staying for the attendant was also made sure. So this is the kind of dichotomy we are talking about in India, the abject poverty which is there. People, there is a disconnect, the communication disconnect, the financial disconnect, and the political disconnect. So we have, various programs in place. The implementation, again and again, I am hammering on that point. That is a problem. How to bridge that is a problem. So mammography, of course, in India, it is there. It is on an elective basis. It is not on a regular basis. We are doing between 40 to 45 years, whomsoever comes and wants to get them done. And any person who has already a history of carcinoma breast in the family, a first degree relative, that person has to be checked 10 years prior to the routine.
What age is that, Dr. Talwar?
So suppose that the mother has got breast cancer around 50 years. So that lady, instead of 40, should be started at 35 or maybe earlier. So slightly earlier than the routine screening which you do, because that person will be on a slightly higher risk as compared to the general population.
All right. Mr. Sharpa, we have to communicate about breast cancer on multiple levels to create that awareness. First is to know your own body, to be aware, to see if something goes missing. Then we have to talk about risk, which could include lifestyle factors, your diet, family history, make them aware of that. Do you think we should also make them aware of insurance and the benefits of that? It's one thing to know about the disease and another to be able to handle it when it comes.
Yeah, I think it's very important. I think very, very, very crucial, because I think the more it's emphasized, the better. That, of course, is there. Because the problem with cancer, particularly breast cancer, where it's a woman who's a lady of the house who's involved, the whole family actually, and typically in cancer case, actually the whole family relocates, and the whole family moves with the patient. So I think the element of financing it, insurance, there are hospitals who have tried on what they call the EMI scheme. They have a monthly, the whole payment is kind of divided into monthly installments. It's worked in some cases it's not worked. I think there are different models which one could look at, but insurance, yes, of course, I think that has to be there. Though I think there's a lot more to be done from an insurance company's point of view also, the way they look at it. I think there is need to tweak that as well. But yes, very important.
Okay, so I'm going to start taking quick closing comments. Dr. Christoph, how can pharma companies collaborate with government health departments to ensure that advanced medicines and therapies reach everyone? what could be done there?
Yeah, I mean, the pharmaceutical companies and especially Novartis, we are looking clearly into that and look into the affordability of the patients on the reality in the countries. And as you clearly stated, and we are aware of that, India is like a continent itself. You have all kind of levels of patients, some with good affordability and others not. And we are constantly striving to look at this, how to customize solutions for all levels of the society in India. But this is, as you can imagine, clearly a challenge. It's not only the treatment there, it's as well the whole healthcare for the patient. Starting from the diagnosis, and as you rightly said, even traveling to the hospital is the first important step, and often already something which is
very unaffordable.
Yes, so clearly we are very committed to be the partner here. We try our best, but we need to work integrated into the whole healthcare system and find common solutions on that. Starting somewhere, not saying that at a certain moment we can cover 100% of the population, but going step by step and increasing what we can do. That's our clear commitment.
Right. Dr. Saida, closing comments from you. How can we involve the community in creating awareness?
Yeah, the media should take a big role, because once the public are aware of what to demand from government, they will demand. See, if they feel that breast mammosonography is important for them, they'll demand that we need breast mammosonography to be done. Like where most of the countries are incorporated that as their election manifesto. Since we don't have that as a public demand, they're not getting incorporated into the political manifesto. So this media should, whatever this women organizations, like you should take that what public should demand. And for public demand, awareness has to be should be propagated from this. Like vaccination. Human papilloma virus vaccination is done in 172 countries. But unfortunately, we have 1 lakh cancer women dying, but we don't have human papilloma virus vaccination incorporated in our country. So this women group, I'm very thankful that a women group has come forward on a breast whole month program, and I really appreciate your efforts. Like this, more and more patient support programs should be made. Like how Western countries are developing is because the patient support groups, and unfortunately our government is taxing on info tax of 300% for the drugs which have been donated free by pharma companies. Like Novartis is giving GPAP drugs free of cost, but that the government is charging 300%. Okay, if you have generic drugs, you can charge it. But when you don't have generic drugs also, you're charging 300% on these things. Or at least whichever countries or whichever drug company is giving free of cost, but that also if you charge 300%, how will the country develop? So all those things we have to make those things aware, and clinical trials. Media should not be as like a spoiler. Like the clinical trials has been made as something so dangerous.
As if Indians are guinea pigs.
Yeah, most of the countries, whenever they don't have a appropriate treatment, they encourage them to put their patients into clinical trials. By that, the patient would get best of the treatment free of cost. So all those things, like why vaccine we are trying, because we don't have any method of treating for COVID, so we are encouraging vaccine. Vaccine trials are agreeable, but clinical drug trials are not agreeable. This is dichotomy of the media and other people.
Yeah, so we need to talk about all of this when we talk about creating awareness.
All of these things has to be made aware to the public, and people who are doing this type of services should be encouraged. We always portray heroines, and we don't portray the people who are doing good job in medical field or pharma companies or anybody, whoever is doing, like your organization is doing. I think they have to be given suitably awarded so that the other people we can join your organization and make this
Make
type
the
of
movement
effort
stronger.
stronger.
All right, Dr. Priyanti Datta, very quickly, your concluding words on how we can increase awareness by involving the community.
I think we can do that very easily nowadays. Technology is the tool, and we quickly have shown it during COVID-19. We have adapted to it very quickly. So I think it's just not at all an issue. So I think technology is the way ahead, and we can do it very quickly as we have done during the crisis time.
Yes, if COVID can make you move so fast, why not on even breast cancer? Mr. Mr. Sharma, very quickly, if the government can have a Beti Bachao, Beti Padhao campaign, why can't it come up with a campaign? Is that what is required, or these multiple campaigns on whatever level, individual, NGO, organization, will that be enough?
Yeah, I think the more nothing is really going to be enough in this. The more that you do, the better it is. I think it has to be everyone's responsibility in that sense. Since Dr. Sairam has already covered what media should be doing, my only request would be if since we have Dr. Christoph also, I think from the science point of view, if there can be some focus in terms of how newer therapies can actually work in this, because this is the era of precision medicine. How that can be focused on, and how that can help in terms of reducing the costs. Immunotherapies, for example, Novartis, for example, the best cases of CAR-T therapy, which doesn't work in breast cancer, of course, but it's very expensive, but a very, very, very important therapy. So I think if there are advancements in that, I think which will also help a lot, because I think in the era of precision therapy, we should be in the lead actually in that. So.
But yes, and Mr. Sharma, technology is only getting better. Medicine is only getting better, so that I'm sure is something we can look forward to.
Yes, I think that
Dr. Tagalwar, I request you to give a closing comment a little quickly. We've already run a little over time.
Well, a lot of things have been told already, but what I would like to emphasize is that first and foremost is a positive environment. You have to say breast cancer is curable. Like you said, Thanda matlab Coca-Cola. You catch a small boy, you ask what is Thanda matlab, pat comes the reply Coca-Cola. So when you say breast cancer, pat should be the reply, yes, it is curable. Till the time you don't have a positive environment, nothing can be done. Secondly is we should not keep on bickering with each other that X is not doing, the politician is not doing, the NGO is not doing. There should be a connect. We should try to take the maximum out of whatever the resources are with us. And I personally feel that the basic problem is with the connect. There is a will, but the communication gap which is there between the patient and the doctor, between the philanthropist and the institution, between the political will and how it percolates down, whether it is the finances, whether it is the grants which are given or the yojanas which are given. That disconnect, I feel, should be, we should join the small dots and try to, minimize that small disconnect which is there. Then I think we can create wonders.
Definitely. Thank you so much for joining us, all of you. And yes, we've got a new slogan. Breast cancer, yes, it's curable. We want to create that positive message, and we want to create the awareness that should you catch it early on, breast cancer, yes, it's curable. A big thank you to all of you for joining us.
Thank you.
Thank you, Anisha, for conducting it so well. Thanks.
Thank you.
Thank you so much.
Thanks.